Thanks for having me, Greg.
Thanks, Dr. Phillips. Maybe I know we've heard this before, but let's give us a little background on yourself and your practice in the area.
Oh, absolutely. I'm a board-certified gastroenterologist, and that means I'm specifically trained in the science of gastroenterology. And what that actually represents is that a long training period. I went to college, went to Princeton University, graduated from there, went to medical school, Washington University in St. Louis, graduated from there, did my internal medicine training at Jefferson Hospital in Philadelphia for 3 years, and then I was selected for a 4th year as chief resident. And then after finishing my chief residency, I'd gone through college on an Army ROTC scholarship, and I went on active duty and was assigned to Fort Leonard Wood, Missouri. And I was internist at Fort Leonard Wood for 2 years. Then I was selected for gastroenterology training and assigned to Walter Reed Army Medical Center for my training. I was trained there for 2 years, and then I was on staff at Walter Reed doing research for an additional 2 years after that. And so a gastroenterologist represents a long
long time
road of training there. But in 1991, I went into private practice, came to Naples, and I've been practicing here since 1991 with Dr. Susan Lebersky, as well as Dr. Neil Randall, Dr. Michael Marks, and most recently with Dr. Ahmed Khatib. And our most recent addition is Dr. Gustavo Rivera. And we have offices not only in Naples in Colonial Square on Goodlet Road, but also in Bonita Beach Road, as well as in Marco Island. So we strive to meet the needs of Collier County as far as their gastrointestinal needs. But it's been very satisfying, and over the years, there's been a tremendous change in the issues that we see in gastroenterology.
We didn't mention the subject tonight, but we're talking about colon cancer screening and prevention. Even though it's been around for a while, it still is very scary for patients, the concept of colon cancer and preventing it, because it is common, and I think sometimes misunderstood. So we're going to get clarity tonight on this issue.
Well, exactly, and this is a good time to talk about it because there's been an evolution, as I said, in gastroenterology. Things are always changing, and there's been an evolution in our understanding of colon cancer, and there's been some recent developments with regard to new tests that I wanted to highlight tonight as well. But for years, it had been understood that screening for colon cancer was worthwhile because early studies in the 1980s and 1990s had demonstrated that if we can detect a colon cancer at an early stage, we could discover it and treat it and make a difference in terms of overall survival and improve the mortality. And so the old strategy, waiting till symptoms and then evaluating an individual, it was becoming increasingly clear with that strategy that people had such advanced disease by the time it was determined that they had a colon cancer that we weren't being as successful as we could. So early studies looking at screening had shown that we could detect cancers at an earlier stage and therefore make a difference. Now, one of the earliest studies that had been performed and showed that you could make an impact was testing for the presence of hidden blood in the stool, occult blood testing of the stool. And by doing that on a yearly basis, the premise was that you could identify blood that was shed from a developing colon cancer. It would be microscopic in nature and likely not observable by the individual, but nonetheless could be detected. And by finding that blood and then evaluating the individual with a colonoscopy, we could specifically diagnose then colon cancer. And it was found that that strategy was effective for improving survival and reducing mortality. And but then the notion was, well, gosh, if we can do a colonoscopy and detect an early cancer, maybe there's an earlier stage of cancer. And what had been presumed for many, many years in the 1980s, that colon cancer just didn't spring up, but it instead went through an evolution where a polyp was first formed, and that polyp over time evolved into cancer. That had been the presumption, but studies then clearly demonstrated that is indeed the case, that you have this sequence where, for example, you have a patch of tissue within the colon that's growing faster than it's supposed to, normal tissue that's growing faster, gradually accumulating one location, not allowed to spread out, and as it accumulates, it develops an appearance that looks much like a mushroom, a stalk, a head to it, but accumulating over a period of 3, 5, 7 years, and then further changes occurring within the DNA of those cells making up the polyp, and those abnormal DNA, which represent the accumulation of mistakes, finally accumulate enough mistakes that a cancer cell forms within the polyp. Then that grows up over a year or two into a full-blown cancer. So the notion was, well, gosh, if we can discover a polyp and remove a polyp, we can perhaps prevent a colon cancer from ever developing. And that was demonstrated in the 1990s, that we can actually prevent a colon cancer from developing by doing a colonoscopy on individuals who are susceptible. Now, inevitably, when I talk to people, they say, well, gosh, there's no history in my family, I'm not likely to get this. But if there's no history in your family, the lifetime risk of an American developing colon cancer is about 1 in 20. If there's a history of colon cancer in your family, like a brother, sister, mother, father, it's about 1 in 10. So there's a substantial risk to an individual, even if there's no experience in their family. And we've encouraged people to be screened, but it wasn't clear what age would be worthwhile to start this screening process. But studies done in the 1990s showed that the incidence of polyps begin to increase around the age of 50. So between that age group of 50 to 60, now we settle on the age of 50, we encourage people to go out and have a colonoscopy done. But I keep saying colonoscopy, and that's important, because not only does it allow you to detect colon cancer, but a colonoscopy allows you to actually prevent a colon cancer from developing. Now, I just assume my listeners know what a colonoscopy is, but let me just digress for a moment. A colonoscopy is where you take a flexible fiber optic instrument about the diameter of a pin, and while an individual is sleeping, we look at the entire extent of the colon or the large intestine, and during that examination, if we see a polyp, we go ahead and remove it and cauterize the site so it won't bleed. And then the individual awakens, and then that's a conclusion of the examination, typically about 10 to 15 minutes in duration. So that's what the essence of a colonoscopy is. Generally in good hands, a very safe procedure, but it has some risk. It has some risks in terms of bleeding or injury to the colon or perforation that can be substantial. And it's because of those risks that there's been an ongoing effort to look, is this really the best tool? Is there other tools that could be used to help screen for colon cancer? And the traditional one I mentioned a moment ago, testing for occult blood, hemoccult testing, it's been learned that although useful, it has a high incidence of false positives. So efforts were made to refine that, to reduce the false positive risk. And about 8 years ago, a very, very specific test was developed called a fecal immunoglobulin test that detects bleeding from the colon, microscopic bleeding, and it's very, very specific. So it allowed us an enhancement of this older tool in terms of screening. But still, the notion was the same, is that there would be a very large polyp or developing cancer that would shed blood that would be detected by this newer tool. Now, just in the last week, there's been an announcement from the FDA as well as Medicare with a new medication, or rather device, that allows us to screen for colon cancer, and it's called Cologard. And it uses some novel technology to allow us to be able to detect a cancer at an early stage. So now we're developing a whole range of different tools to not only screen for colon cancer, and once again, colonoscopy allows you to screen but also prevent. But there are some circumstances where a colonoscopy is not right for everyone, or not preferred, and individuals want to have some other type of option. and instead of undergoing that examination. By the way, you might say, well, gosh, with such great tools, why do you need to have other tools available? You know, for example, a colonoscopy is extremely accurate, up to like 95% in terms of detecting issues. But the trouble is that even though we have these better screening tools, colonoscopy, easier screening tools like hemoccult testing, only about 45–50% of Americans who should have a screening examination done are having a screening examination done. So it's been a great frustration as you see the possibility of preventing colon cancer, reducing colon cancer deaths, and realize that perhaps more than half the individuals who benefit are not even bothering to have any kind of screening test done. And that's true, those numbers I've just described to you is applicable to Medicare beneficiaries in particular, but it's even higher in individuals who are not Medicare beneficiaries, in that age group from 50 to 65. So that's been some of the impetus, that's been some of the driving force behind trying to find newer technology to screen that would be sort of appealing to individuals. And well, let's just stop for a moment and talk about Cologard, because that's that particular device that was recently released. And it uses, as I said, a novel technology to allow us to be able to detect a colon cancer. Now, Greg, what I was telling you earlier is that colon cancer represents an accumulation of genetic mistakes. And this is kind of slick in terms of the technology. But cancer cells within the colon, as they evolve, they divide, they grow, they get older, they die. And when the colon cancer cell dies, it's released into the lumen or into the gastrointestinal system and is passed out with the stool. Now, DNA, which represents the contents of each cell, cancer cell as well as normal cell, is fairly stable molecule, and it's not digested, it's not broken down within the colon, and so the DNA of cancer cells can be actually detected using this technology called a polymerase chain reaction, which allows us to detect tiny amounts of certain DNA. Now, knowing that cancer cells have very specific genetic mistakes, that is to say abnormalities in the DNA that represents mistakes, we're able to detect that DNA in the stool, those abnormal DNA in the stool, and thereby know that likelihood that there's some type of cancer within the gastrointestinal system, usually the colon itself. Now, the accuracy of this, about 92%. That is to say, if you detect an abnormal DNA within the colon, 92% of the time, it's related to a colon cancer. And that would prompt, if you had an abnormal result then, would be to go ahead and to do a more specific test like a colonoscopy to find that colon cancer. In terms of this test, this Cologard test, it's done at least on an annual basis. So it's not clear whether it should be done every 2 years or every 3 years at this point, but it's done on a recurrent basis. And the way it's done is you take a specimen of stool and you collect it and put it in a special container. They're trying to see if FedEx or UPS will pick up these containers. In some of the meetings, it was called a poop on the scoop, and poop on the stoop that would be picked up.
On the stoop.
Yeah, that would be picked up by the FedEx.
Amazon will be on that.
Yeah,
with their remote aerial vehicles.
Yeah, they'll helicopter it in and out.
We're gonna take a quick break and talk in more detail about how those collections might be made. After a quick break, we'll come back.
All right. So.
When picking a realtor, don't just pick anyone. Pick someone with experience. Pick someone with a proven track record. Pick a realtor like Jim York from Downing Fry Realty, the #1 brokerage with the most real estate transactions in the area.
My husband and I had very specific ideas about what we wanted in our new home. Jim York was able to help us find the home that was ideal for us.
With over 20 years of real estate experience in Southwest Florida, Jim York has negotiated over $200 million in sales contracts. Selecting the right realtor is a critical decision that can earn you thousands when selling or save you thousands when buying.
Jim also helped us with a mortgage lender and a good real estate attorney. He went that extra mile, and his experience says it all.
Call Jim York for a no-obligation meeting at 239-273-6727 or visit his website, www.naplesyorkrealestate.com.
Yeah.
Welcome back to Dialogue with the Doctor. We're here with Dr. Raymond Phillips talking about colon cancer screening and prevention. And we're talking about a new test called Cologard. And we've got a flood of phone calls in my office about this product. But we really need to know how to use this product. And
Well, as we were just discussing a moment ago, there's a number of different screening tools that have been developed over the years. And we talked about colonoscopy to detect, and also detecting microscopic blood in the stool. But the Cologard represents this novel technology where you're detecting abnormal DNA within the stool, DNA that's derived from colon cancer cells that have been shed into the gastrointestinal system. So without going into great detail, an individual will take a sample stool, will submit it for testing. If abnormal DNA is found within the stool, then there's a 92% chance there might be a colon cancer in that individual. That particular test, though, is not effective for detecting polyps in any effective fashion. So it's a test to try to detect colon cancer at an early stage, or to detect colon cancer before it's manifested itself as symptoms. And so generally, so an individual will do this test, they'll submit a stool test to their doctor's office or to a laboratory. The laboratory will conduct the test and give the result to the individual's physician. And then at that point, if it's a normal test, well, nothing further presumably would need to be done in that individual for a year, perhaps 2 years. On the other hand, if it's abnormal, then it needs to be investigated, because as I said, there's up to a 92% chance there could be a colon cancer. So in order to investigate it, it will require colonoscopy at that point to identify where that cancer might be. Now, there are some limitations to this test. One is that it will detect abnormal DNA in the gastrointestinal system from anywhere throughout the gastrointestinal system. So, for example, if someone has a developing stomach cancer or pancreatic cancer or small intestinal cancer, it'll detect the abnormal DNA. So if an individual has an abnormal test and a colonoscopy is normal, additional tests will need to be done to look to see if there's anything else, see if there's any other abnormality within the gastrointestinal system. The other point about this test is that it's, and I'm just repeating myself, but it's not effective for detecting polyps at any early stage. It's only about 40% effective in that sense. And as a result, it's not useful for detecting polyps.
I think the point that we were talking about was if it's not effective in if somebody has a colonoscopy today,
Mm-hmm.
and there's nothing there, it takes 5 to 7 years for a polyp to grow and develop a cancer. Well, that would mean if you had your colonoscopy, doing a Cologard test in the first year, second year, third year, or fourth year, it seemed like a waste of money.
And it is. And
it's expensive.
And it's expensive test. It's right now, I believe they're marketing it at $600 a test, which is substantial. And so it's important to understand with regard to colonoscopy, hemoccult testing, where this particular tool should lie and how it should be used. An individual who has had a colonoscopy and is told that the colonoscopy is normal, and say it was done last year or 2 years ago or 3 years ago, and they're told by the gastroenterologist, yeah, it's normal, come back in 10 years. They don't need any other test done in that 10-year period. If you've had a very well-done colonoscopy and there's no family history and individuals having no symptoms, then a 10-year interval is suitable. If an individual has had a polyp removed on a previous colonoscopy and they're told to come back in 5 years' time, as long as there are no new symptoms, the individual does not need to do any other tests within that 5-year time frame. So the Cologard is not for those individuals who have had colonoscopy before. Rather, instead, the Cologard test is useful for individuals who, for whatever reason, don't want to do a colonoscopy, or, for example, they feel like their health is fragile enough that they don't really necessarily want to undergo a sedation for a colonoscopy. And that raises another controversial area, is that colonoscopy, although a very effective tool, a very safe tool, as an individual ages, there is a time point where the colonoscopy should not be done on a routine basis for general prevention. And that's an individual decision between the doctor and the patient, but generally the guidelines for that is that if the individual is in good health and has a potential living an additional 10 years' time, then it's worthwhile to consider a colonoscopy. If, on the other hand, the individual's health is declining and they're fragile, then in that circumstance, probably a colonoscopy is not the best tool to use for screening. And you might say, well, gosh, if a person's 70, then should they have it done? The difficulty is it depends on that 70-year-old's individual health. In Naples, people seem to live longer, seem to be healthier, and so the age is much, much higher than that. But in other parts of the nation, well, individuals, an individual's practice of a physician's practice may include a number of individuals who are very fragile by the time they get to age 70. So it's a circumstance that needs to be individualized, but it depends on the patient's particular health. But Cologard, I think, will fill a niche for those individuals who don't want a colonoscopy, or in whom their health is a little bit fragile and they don't want to risk a colonoscopy. It might have some benefit in that group. But as far as its role, again, its role is to detect colon cancer. It doesn't prevent colon cancer. So it's important to understand that there's a subtle difference there. And again, individuals who've had colonoscopy, they don't need to have a Cologard test too. Mm-hmm. Increasingly, when we practice, we like to be effective about what we do. We like to be very effective on what we do. But in this environment that we're in right now in terms of healthcare, we like to be very, very cost efficient. And nothing wrong with being thrifty, but you want to be effective and thrifty, and don't want to be duplicating tests. And because when you start duplicating tests, when I say duplicating tests, doing a colonoscopy plus a Cologard, you're spending extra money that you don't need to spend, and you're not necessarily improving an individual's health. Mm-hmm. So there's a role for it, and the role is not altogether completely clear on an individual practitioner's basis. So it is worthwhile if an individual has not had any screening at all and has been reluctant to undergo a colonoscopy, well, that Cologard test may be a useful alternative to consider, and certainly it's far better than doing nothing at all. And now there's a whole range of options, and doing nothing at all increasingly becomes clear that if indeed you develop colon cancer, it's not something that you necessarily can escape. It will cause you symptoms. It will require some type of intervention because it will lead to a blockage. It will lead to intractable bleeding. It will require an operation. So those individuals who want to emulate the ostrich and just stick their heads in the sand and say, I'm going to ignore this and it won't bother me. Well, it will. If it's present in your system, it will bother you at some point. So it does behoove you, to try to either prevent it or detect this problem at an early stage when it can be handled efficiently and effectively in terms of maintaining an individual's health.
So in terms of guidance with Cologard, will we be given, I understand the guidance you're giving us, but is there any official guidance from the manufacturer of this product telling us how it should be used?
Well, there isn't. And there is to the extent of the first time use.
Okay.
That is to say, first time use would be an individual who's eligible for screening after the age of 50 or who, for whatever reason has not been screened in some fashion or doesn't want to have a colonoscopy or can't have a colonoscopy for medical reasons. It would have a role in that circumstance. But the recurring use of this, that is to say, an individual has this at age 65 and it's normal. Well, what do they do at age 66 or 67 or 68? And it's not really clear what interval should be pursued.
So it's not a substitute for a colonoscopy.
It's not a substitute for those individuals who cannot or will not have a colonoscopy. I think it's a good alternative.
Okay.
But as far as if the question is which is a better test, all things being equal, the colonoscopy is the best test because not only does it allow you to detect a problem in terms of a cancer, but it allows you to prevent a problem in terms of polyp and prevent it from maturing into cancer. Oh, by the way, if the Cologard test is abnormal, you are going to need a colonoscopy because all the Cologard test tells you is that there's a colon cancer somewhere in the 5 feet of your colon, and you don't want to be removing your entire colon. You want to have a little bit, give the surgeon some clarity about where this is so they can refine their technique and identify that. That means having a colonoscopy.
Well, I'm very happy that you're giving us clarity on this test.
Thank you very much.
I really appreciate you coming and talking to us again about colon cancer, and we look forward to having you back again.
All right, thanks, Jim. Greg, I enjoyed being here.